Good evening, everyone. Today is another webinar. Welcome to our webinar series. Today we are going to discuss about management of hematuria. It's another very important loan case in your final MBBS exam. Today our speaker is Dr. Ranga Wickramarachchi. You know, Dr. Ranga is a well-known GU surgeon in Sri Lanka. He graduated from University of Sri Jayawardhanapura. He got his postgraduate MD from Colombo and got postgraduate overseas training in the UK. He worked as a GU surgeon in Ampara, and after that he joined Sir John Kotalawada Defence University. Now he is a senior lecturer there, and I think he's an ideal person to discuss in this topic. I think that that's the time to Dr. Ranga to start his presentation. Dr. Ranga Wickramarachchi.
Okay. Thank you, Dr. Dixon, for the introduction. So I will start with the case scenario. Let me share the... I hope that everybody can see the screen. And
Yes,
this is going to be an interactive discussion. So I would like the participants to answer and interact with me. That will keep the momentum and then the enthusiasm going, especially around this time towards the end of the day. Okay, this is the brief history that I want to discuss. A 65-year-old man, a heavy smoker, a known diabetic on treatment, presents to surgical clinic with intermittent visible hematuria for 2 weeks. He has a history of urinary calculation disease in his 30s, which was managed conservatively. Okay, so let me get the input from the audience, the listeners. So what are the key words that you want to pay attention or highlight in this particular given scenario? Feel free to contribute, then only I can proceed.
Sir, intermittent hematuria.
Okay, intermittent hematuria, right? Anything else?
65 years old, heavy smoker.
Okay, 65 years, quite correct. It's important that we focus on the age. We will discuss why it is. And as you said, heavy smoker, that has a bearing.
Having chronic comorbidities like diabetes mellitus for 15 years duration.
Okay, long-standing diabetes. Of course, we don't know the control, but it's a long-standing diabetes, correct?
History of urinary calculation disease in his 30s.
Okay, during his early days, in his 30s, he has had urinary calculation disease, which was probably managed conservatively, now so no intervention made. In addition to that, I prefer, even if you focus on that word, man. So, if we take whatever we have discussed so far into a highlighted form, now you could see the keywords. So, age is important. The gender being a man, it's important. Heavy smoker, diabetic, chronic diabetic, intermittent visible hematuria for 2 weeks. And about the calculation disease. So remember these highlighted words, and each and every stage I'll come back to you and I'll ask questions why these are important. Imagine this is the patient given to you for your long case in the exam. So you have 20 minutes, rather 10 minutes to go through and then to get the history. So how do you proceed? Before that, I would like to just go through the theory around this topic. few essential areas. So my first question, what do you mean by hematuria? Any idea? Students.
The presence of red blood cells in urine.
Okay, the presence of red blood cells in urine. Quite correct. Now the second question, when you say presence of red cells, how many red cells? Let's say somebody coming to you and showing the report saying there's 1 to 2 red cells. Is it significant? Another one showing 10 to 15 red cells. Or maybe red cells feel full. So which is significant?
So more
Sir,
than 3 red blood cells in the high power field.
Okay, so when you look at the urine analysis, the urine full report, you are looking at the urine sample under high power field. So you mentioned 3 red cells. Any other answers?
So more than five.
More than 5. Another answer. Okay. Anybody? Any different answers?
In men, 1 red cells is significant. In women, more than 1 or 2, more than 3 red blood cells.
Yes. Now let me come back to the topic. Don't get confused. Now, if you go through different literature written in the different era, maybe 5 years, 10 years back, or then latest, and you will see different number of red cells. The cutoff number is quite different from article to an article. Now, if you look at the UK guidelines, the most of the articles they consider the cutoff red cells is 3. They are a bit worried, and if it is more than 3 red cells, then they are worried. On the other hand, Americans, they are quite not too worried initially, so they wait until about 10 red cells appear. So the American guideline, most of the guidelines, they talk about 10 or more red cells. In general, if you adapt a guideline, most of the international guidelines, we consider it significant when it is more than 5 red cells. At your level, undergraduate level, I would say if you take more than 5 red cells, even for your clinical practice, in that matter, if you take more than 5 red cells, that is significant, and that is considered as significant hematuria. And somebody mentioned the difference between 2 genders. I do agree. Some time back it was the case, and they have given 2 different definitions of male and female. But to avoid confusion and to avoid unnecessary jargon, they have removed that part. Now, whether it's a male or a female, we don't give any demarcation. So either genders, we consider 5 red cells as the cutoff line to be significant. So now the term, if you go through back to my history, you saw I have mentioned the word visible hematuria. So apart from visible hematuria, any other type of hematuria you know of?
Microscopic.
Okay, microscopic hematuria. So I would rather suggest if you say microscopic, you better call it macroscopic hematuria. So why do you think I have used a different term? Any idea? Again, it's just a terminology. In the modern day practice, we use visible hematuria as opposed to non-visible hematuria. These are the modern terms that we use. So what do you mean by visible hematuria?
We can see red color urine in naked,
Yeah, you can see red
eye.
color urine. If it is fresh blood, fresh bleeding, you will see bright red color, or maybe even a pinkish color or tinge of blood. If it is old bleeding, maybe altered blood, you will see more of a brownish, brick red or brownish color urine, depending on the time interval. So when you say non-visible hematuria, it's slightly different. So let me share a different set of slides. So that will help us to go through this. So this is where we are. Visible versus non-visible. So visible, which is the one we have considered macroscopic or gross hematuria in the old terminology. So when you say non-visible hematuria, that includes both microscopic hematuria as well as dipstick hematuria. Anybody who has heard about dipstick hematuria? What do you mean by dipstick hematuria? Any thoughts about it?
When a dipstick test is done for another reason and then you find that it's red.
Not necessarily it's another reason. For the same reason, we know a lot of testing, it's much easier now. You can test with a small strip. Now we know beta HCG, urine beta HCG, we check with a strip. Similarly, if you go to other countries, the Western countries, you will encounter whenever you give the urine sample, the nursing practitioner or the nursing officer will dip a small strip and looking at the color change. There are different segments, and depending on the different color changes, they will say whether there's hematuria or not. So if your urine sample is positive for the dipstick test and which is positive for blood, that is called non-visible dipstick hematuria. Both are non-visible, microscopic. When you say microscopic, that indicates you are going to examine the urine sample under the microscope. That is the difference. So what is the big deal? Why do you think you have non-visible and certain people you have visible hematuria? Why do you think? Why there's a difference? What does it mean to you? When one patient comes and say, like our patient here, I'm having visible hematuria. I have seen red colored urine. On the other hand, another patient, he will say the urine is quite crystal clear. But when you test, when you examine under the microscope, or maybe if you put a strip test, it's positive for blood cells. You can see blood cells under the microscope. What is the difference? What do you think?
Concentration of red blood cells would be higher in the visible hematuria.
Yes, it's a concentration and which is proportionate to the degree of bleeding, severity of bleeding. If somebody is having a significant bleeding, quite a significant bleeding, obviously the urine color will be changed and you can identify red cell, you can identify red urine with your naked eye. On the other hand, when the concentration is less degree of bleeding, you may not see with your naked eye, but of course, if you examine further, by testing, you will identify there's blood in urine. So, which is a indication of how severe the hematuria is, the severity of the hematuria. Now, let's say you are having visible hematuria. In history, whenever they say visible hematuria, you ask about clots. So, why do you ask about clots? Passage of clots. What is the significance? Anybody?
There might be a significant bleeding, sir, to form the clots.
Yeah, there's quite a significant bleeding, and which is very high degree of bleeding, and which is good enough for them to form clots inside the body before they pass as blood. So that indicates where there's very significant bleeding. That's one end of bleeding. That's where you get the clot formation. So now let's say you have a patient. Now our patient, he had visible hematuria. On the other hand, you have another patient in the clinic. When you test, it becomes positive for red cells. Just one sample, patient is clinically otherwise perfectly well. Are you worried? When do you think it's significant? Non-visible hematuria. Are you
It's
happy with
present
single
in,
sample?
if it's present in 3 consecutive samples,
Uh-huh.
at least a week apart in each, then it's significant.
Yes. So you need to look at least 3 samples. And remember, there are 2 things you need to exclude. The common things are common. Menstruating females, make sure that you are not dealing with a menstruating female at the time of collection of the sample, because it could be simple contamination. That's number 1. When it comes to females, always check that. Childbearing age, always check whether they are menstruating. Because if they are menstruating, obviously no point the interpreting the sample, which is going to be positive invariable. And the other thing, some people, if they have vigorous exercise, maybe after a session of gym or maybe after a session of jogging, and if you test the sample, sometimes which can be positive for microscopic hematuria. So which is not a very good representative sample. So those 2 conditions you need to exclude. And about dipstick hematuria, it's important, it's very sensitive. That's good. However, the bad side is which is not very specific. In other terms, you have higher rate of false positivity. Even without red cells, you will get a positive results. There are so many other things which can interact. It's a chemical reaction. So there are other things which can that trigger the same chemical reaction, giving rise to false positives. Those who are a little bit interested, homework, go home and read about dipstick hematuria and read about the chemical reaction there and the color change. So therefore, we always recommend, if you get a positive sample for the dipstick hematuria, always send the sample for microscopic hematuria evaluation to the laboratory. So they can see under the microscope and see, they can check whether there are obvious red cells visible. If the red cells are there under the microscope, then it confirms that this patient is having non-visible hematuria. Okay, so why do we bother? So why do we bother about hematuria? Well, now we talk about hematuria in this webinar, and then in the ward class you discuss. If you go to any urological unit, they will teach you about hematuria. Why are we worried about hematuria? Anybody?
Because hematuria can be due to malignant causes.
Okay, yes. Hematuria may indicate or signifies presence of a malignancy in the urinary tract. Blood in most of the areas, which is alarming, a red flag sign. For example, bleeding per rectum. Commonly, lay people may attribute it to hemorrhoids. But we know, other than hemorrhoids, there are so many other causes, and out of which one is colorectal cancers, which is the sinister cause. Similarly, you can name number of causes for hematuria, but why we bother? Because which is an indication of an underlying urological malignancy. Now here I have put, if somebody asks you to list down the causes for hematuria, remember, if medical team, if they ask, they are mainly focusing on medical causes. And I hope all of you all know, and they are very fond of their glomerulonephritis and all the other medical causes. But obviously, if you get a surgery long case, please use common sense. We are not focusing on glomerulonephritis. We are mainly talking about urological causes, that is bleeding from the urological tract, urinary tract, which is starting from the kidney, renal pelvic ACL system, ureter, bladder, maybe the urethra. So there are different causes at different points. So can somebody mention few common urological causes of hematuria, please? Now say this particular patient, he's a 65-year-old guy coming with visible hematuria, and if you are in the clinic, what are the differential diagnoses? Or maybe you are doing your long case. You get the same case for your long case. What are the differential diagnoses you want to entertain your list?
First, I want to exclude any urinary tract malignancies. So
Okay, good.
that would
So
be
you are quite worried and you want to exclude urinary tract malignancy. Totally agree. Both hands up.
then such as the renal, bladder, or upper tract urothelial carcinoma, and then the other causes could be due to a urinary calculi, causing a
Okay, so
traumatic
apart from
bleed.
malignancies, if you leave the malignancies apart, the other common causes are common. So one common cause is urinary calcular disease, right? Which could be renal, ureteric, or the bladder. What else?
Then it could also be due to UTI.
UTI, yes, UTI is very common, particularly if you both compare males and females. Who are at higher risk of getting recurrent UTIs?
Females.
Females, obviously. And the other thing, females, if they get cystitis, and quite a significant proportion of females, they do bleed. You call it hemorrhagic cystitis. Males, which is less common, but females, it's much common to see visible hematuria when they get cystitis. Of course, non-visible hematuria you may see in both groups, but visible hematuria with cystitis common in females. Right, agree. Number 2. What else?
If it's a torrential bleed, then it could be due to BPH, benign prostatic hyperplasia.
Okay, yes, prostate is another common culprit. Now, a moment you think about hematuria, you may wonder whether it's a prostate cancer. However, if you look at the real numbers, the figures, BPH, benign prostatic hyperplasia, gives rise to hematuria much in higher numbers, or very common as compared to prostate cancer. Prostate cancer doesn't bleed that much. It can bleed, especially if it invades into the bladder. But otherwise, hematuria alone is a rare symptom or less common symptom of prostate cancer. However, benign prostate hyperplasia is very common. When you get BPH, you get the abnormal, tortuous, very fragile blood vessels forming around the bladder neck area, and suddenly they rupture. These patients, they can end up with very significant, very severe torrential hematuria, visible hematuria. In fact, usually these people, they present with clot and clot retention, and which is usually continuous when they start bleeding. Okay, anything else you want to add?
Renal tuberculosis.
Yes, renal tuberculosis, it's not again a typical feature to get bleeding. More than bleeding, you get sterile pyuria, which is the classical teaching. The hematuria is a rare one. So I would say you need to put them down further down in the list, don't mention. So if I ask you to give differential diagnosis for hematuria in any age group, think about malignancies, UTI, calculi. Calcular disease could be in any part of the urinary tract. And of course, elderly people, at least beyond 50-55, then think about BPH also. So these are the common differential diagnosis for visible hematuria from urologist point of view. And the other thing now you may wonder whether there's an age limit, age barrier for the malignancy. What do you think?
There's no age barrier.
There's no age barrier. If you look at the old guidelines, now maybe 10 years back, even the Sri Lankan guidelines, we were mainly focusing on patients more than 40 years presenting with hematuria. Now we don't think about the age, we don't consider age as an important factor, because even we commonly see even in young people. Now if I take last 10 RCCs, renal cell cancers, about 4 patients, they are young people less than 40. So therefore you can't take a chance. And mind you, the youngest chap that I have seen with a bladder cancer was less than 20 years. So therefore age is not a good guidance for you to decide whether it's going to be a sinister pathology or not. Therefore, irrespective of the age, worldwide, now we consider hematuria is definitely a red flag sign, which needs proper attention. Now, if you want to take down few figures, if they present with, obviously with the advancing age, the malignancy risk is higher. So if you are dealing with a patient more than 45 years, if they present with visible hematuria, chance of having a malignancy in the urinary tract is 14%, quite high. Whereas if they present with non-visible hematuria, persistent non-visible hematuria, I'm using the word persistent because that has to be confirmed with more than 3 or more samples. So if they have persistent non-visible hematuria, chance of having a urological malignancy is about 3% if you want to get numbers. So that's why we are really worried about hematuria. Okay, so I'm going to switch the slides again, going back to my old one, your case summary. We have dealt with this up to this point now. Okay, now what are the risk factors? Now going back to your patient, this history, are there any risk factors? Now we know we are looking at a patient of 65 years, a male patient, and who's a heavy smoker. So if you think about the common differential diagnosis, particularly urinary tract malignancies, out of 3 malignancies, what is the commonest to give rise to hematuria?
Bladder.
Bladder tumors. Bladder cancer is the commonest. So number 1 culprit is bladder cancer. Next to the bladder cancer, what is the next common?
Renal.
Renal cell carcinoma, renal tumors. That's the second common, the commonest one. And the third one, if you want to list?
Upper tract urothelial.
Yeah, upper tract urothelial cancers. Now remember, upper tract urothelial cancers, they are of the same variety as the bladder cancer, but they are at a different location. So therefore, we classify them as a different category of a disease, different class of a disease. So you have the bladder cancer, the commonest, followed by the renal cell carcinoma, and then you have the upper tract urothelial cancer. So those are the terms that we use in modern day: bladder, renal cell, and the upper tract urothelial cancers. These are the 3 cancers that we are going to discuss under an adult having hematuria. Okay, so what are the risk factors in the given history? Now, if you concentrate in these 3 cancers, now what are the risk factors that you could pick up in this given history?
Heavy smoker.
Heavy smoker, very good. What the smoking is a risk factor for which cancer?
Bladder cancer.
Bladder cancer. So if you look at the bladder cancer, the leading cause of bladder cancer is smoking. So that's, I agree, number 1. By the way, do you know other risk factors for bladder cancer?
Occupational exposures to things like aromatic hydrocarbons, paints, dyes, rubbers.
Yes. So the aromatic hydrocarbon is another category, and the bladder cancer classically it's the cancer with chemical carcinogens. So these chemical carcinogens, they can involve so many chemicals and so many industries. So azo dyes, aromatic hydrocarbons, and so many other heavy metals and things. If you look at the industry, as you said, paint industry, spray painting is the worst, and any paint industry. And then you have the textile dyes, and you have petroleum industry, and so many industries, rubber. These are all using chemicals. These chemicals are quite high risk to give rise to bladder cancer, provided you have a prolonged exposure. So remember, if you are getting that history, it's always important how long have they been smoking. That is important. And how long have they been exposed to particular chemical. Say one fine day you go and paint your house and don't think that's a risk factor. But say you have a car painter, vehicle painter, or maybe I had ladies who are the batik workers. who have been involved with batik industry. They have been doing that for a while and they are getting good exposure. And then the petroleum workers and people who are working with machinery and they are exposed to a lot of hydrocarbons over a long period. So the duration of exposure is also important. Okay. So you mentioned smoking as a risk factor for bladder cancer, and then somebody else mentioned carcinogens, chemicals. Anything else?
Chronic inflammation of the bladder.
Yes, chronic inflammation due to chronic irritation. So what are the things which can chronically irritate the bladder?
Indwelling catheters, stones.
Yeah, well, indwelling catheters, I would say not a very good answer because then that will frighten our patients. A lot of our patients are on long-term catheters, but to be honest, I have not seen a big difference between bladder cancer prevalence or the incidence between these two groups, whether you are having a catheter or not. More than the catheter, what are you looking at?
Recurrent UTIs,
No,
recurrent
not no.
stones.
Don't mention recurrent UTIs. Give
Parasitic
me two
infection.
common things or other.
Previous
Parasitic
radiotherapy
infection.
exposure.
Yes, parasitic
Bladder
infection. What parasite are you really talking about?
Schistosomiasis hematuria.
Yes, schistosomiasis. So that's a known parasitic infection. Where do you find this parasite?
The Middle East and the water.
Yeah, mainly the certain parts of the Africa and then the not really the Middle East or further beyond the Middle East area. And you need to have the completion of the cycle. So you need to live in that particular region to get the disease from the parasite. Just because you just get exposed and come back, you don't get the disease. So you have to live in that particular area, the region, right? Anything else which can chronically irritate the bladder?
Recurrent calculi.
Yeah, bladder stones, long-standing bladder stones beyond 10, 20 years. Imagine you have a large bladder stone sitting in the bladder for more than 10, 15 years. Chronically, bladder is getting irritated and you can get you can get dysplastic changes and the metaplasia and dysplasia and the malignancy. So if you look at the classical, what is the classical bladder cancer, the histological type?
Urothelial, which is transitional cell.
Yes, urothelial, which is transitional cell, as opposed to urothelial. If you get a chronic irritation due to a parasite or maybe long-standing large bladder stones, and what type of cancer do you think you get there?
Squamous.
Squamous cell, yeah, because you get the squamous metaplasia and followed by dysplasia and squamous bladder cancer. And any other variety that you know of?
Adenocarcinomas.
Adenocarcinoma, usually you see in small group of people following
bowel
congenital
metastasis.
Persistent uricus.
Yes, urachal remnant, if it is persistent, which can undergo neoplastic changes. Or else it could be a malignant, the deposit from elsewhere, the invasion from a nearby structure, usually GI tract or maybe the prostate. That is the other situation where you get adenocarcinoma in the bladder. So remember, it's commonly urothelial, right? So we are worried about the smoking because it's one of the leading risk factors for bladder cancer. Any other urological cancers you could get due to smoking?
Renal cell carcinoma.
Renal cell carcinoma. Then again, the smoking is the leading cause for renal cell carcinoma. So what are the other risk factors apart from smoking for the renal cell cancers?
Hereditary family histories.
Yes, there are certain genetic predisposition, family history. If you talk about familial cancers, and one good example is RCC. Can somebody name few examples of familial diseases which could lead to RCC, pre-malignant conditions?
Polycystic kidney disease.
Polycystic, yes, but it's not very common. But there are certain other common conditions where you need to think about.
Von Hippel-Lindau syndrome.
Yes, von Hippel-Lindau. One of the conditions, you just, for those who are looking at distinctions, go and read around. That's a condition where you get so many other things. And one abnormality, they can develop RCC. Anything else?
Exposure to things like petrochemicals and dyes.
No, any other genetic ones, the familial ones, apart from one down?
Hereditary papillary renal cell carcinoma.
Yes, hereditary papillary renal cell carcinoma is another variety. And if I ask you to name one more?
Burt-Heg disease.
Yes, Burt-Heg Dubé. And then just go and read about these topics. And those who are interested, you can do some extra reading about these topics. I'm not going to touch upon that then. Right. So you have a big category, the familial. Right. What else?
Exposure to asbestos, cadmium.
Yeah, now the new theory, they think even the RCC, there could be certain exposures to chemicals, especially the arsenic, asbestos, cyanide, and so many things, right? What else?
Hypertension, obesity.
Long-standing chronic hypertension is a well-recognized risk factor. Anything else for the blood renal cell cancer?
Obesity.
Obesity, yes. Obesity is a known risk factor. So remember, if you look at the renal cell cancer, smoking, and then the long-standing hypertension, obesity, and then the familial genetics, and then you have the exposure to certain chemicals. Right. So if you look at the upper tract urothelial cancers, same as the urothelial like the bladder, so the risk factors are the same. Remember that way. It's easy. So now I have highlighted 65 years. Why do you think I have highlighted 65 years?
The risk of malignancy increases with age.
Yes, with the advancing age, risk of urinary tract malignancy, in that matter, most of the malignancies, the risk is getting higher and higher. If you look at the RCC, if you look at the bladder cancer, upper tract urothelial, majority of your patients going to be more than 60 to 65 years. But the landscape is slowly changing. Now we do see quite a number of young patients, as I mentioned, but classically, you will be looking at elderly population. And why? What is the significance of the gender?
Renal cell and bladder cell carcinomas are more common in men.
Yes, not only the RCC, even the bladder cancer. Even if you eliminate the smoking, the habit, still the men are at a higher risk of developing urinary tract malignancies, both bladder, renal cell carcinoma, and upper tract urothelial. So being a male, gender is also a risk factor. So if I ask you to list the risk factors, in this case, smoking, being a male person, 65 years, all of these are risk factors. Remember. Right. So we will move on. And somebody has asked the chronic dialysis, whether it's a risk factor for RCC. The answer is yes. There's a slightly higher risk of getting RCCs on people who are on chronic dialysis. Okay. Now this particular history, if I ask you to give the differential diagnosis, what is the first one you want to give?
Bladder cancer.
Bladder cancer. Number 2?
Renal cell cancer.
Renal cell carcinoma. Number 2. Number 3? Number 3?
Upper tract urothelial.
Okay, upper tract urothelial. Number 4? Now we are coming to maybe benign causes.
Urinary calculi.
Urinary calculi. Obviously, this patient has a history of urinary calculi disease. I have given that part of the history for you to think about that aspect as well. Okay. And what else?
BPH.
BPH, because you are looking at a man, age 65-year-old man. So with age-related BPH could be there. So that's another area that you need to focus. And okay, I'll come to that point later. There's another point I want to highlight. Okay, now the real clinical part, your long case. How do you clinically evaluate this patient? . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . . I'm hearing only few voices. I would like more people to contribute and communicate. That's much better than just a few voices through the platform. When you say clinical evaluation, what are the areas, the segment that you are going to focus?
History and examination.
Obviously, history and examination. Now, I want all of you all to come out with the answers. In history, what are you going to ask? Now, you know the background. We have been discussing about the hematuria, the significance, and possible differential diagnosis. Let's say this is the same patient you get for your long case. And so, in the history, what are the other things you want to ask? So, why do you take the history? First thing, you want to focus on the hematuria, the severity, the extent of the problem. Number 2, you want to know about underlying cause, the etiology. Number 3, you want to look at possible risk factors for the causes you have mentioned. Number 5, you want to look at the complications due to hematuria. Or if it is a malignancy, number 6, you would like to get some idea about clinical staging, the extent of the disease, the spread. So those are the things you would focus. And then later, if you are thinking in a surgical mind, if you look at, you will think about take the history, thinking that you are preparing this patient for a possible surgery. So those are the areas you want to cover in your history, and same as in the examination. So any patient, I would say that is what you are going to assess in your 10 minutes. So tell me, in this particular patient, what are the additional things you want to ask in the history?
Is it painless or painful hematuria?
Okay, painless, painful. What do you mean by painful hematuria? What do you mean by painless hematuria?
With the hematuria, is there any associated loin to groin pain?
Yes. What you mean by pain is you are referring to colicky pain, not merely the dysuria. Otherwise, most of the patients with hematuria, they will come and say they have some degree of dysuria. Doesn't mean that they fall into the category of painful hematuria. When you say painful, that you are referring to colicky pain, which is classical ureteric colic, loin to groin pain. So let's say you have a patient with painful hematuria. So what are the possibilities?
It could be due to calculus or due to clot.
Yes. Commonly, you think about classical teaching, you think about calcular disease. That's where you get a classical colic, ureteric colic, when there's a stone moving down, migrating down. But remember, not always. Sometimes the patient may be having a RCC and they bleed. They form small clots in the renal pelvis. These clots, when they pass down the ureter, patient can develop colicky pain. That is called a clot colic. So earlier, good olden days, the teaching, when we say painful hematuria, you tend to forget about your malignancies, but not any longer. Even with painful hematuria, you need to think about whether it's a RCC, because you can, or maybe upper tract urothelial cancer, because people can have hematuria with clots and clot colics. Painless hematuria, then you are more towards the malignancy. But again, remember, even sometimes the calcular disease, renal or ureteric calculi, people can have painless hematuria, though you expect them to have pain. So there's quite a significant overlapping. Whether you ask about painless or painful, it doesn't matter. There is no big difference to me. But remember, the chances of having a malignancy is much higher if you have painless hematuria. Okay, number 1, pain. Anything else you want to ask?
In regards to the hematuria, is it clots or red urine?
Okay, if it is clots, the color, whether it's bright red, brick red, or maybe altered brown color, when the color changes occur, then you know it's a altered blood. There is unlikely to have significant acute bleeding. But if it is fresh blood, bright red, you know acute bleeding going on. And similarly, as I mentioned, if you see clot formation, there is quite a significant hematuria, which is allowing the clot to form inside the body, so that's why they pass clots. Let's say your patient says they are passing clots. Anything else you want to ask about clot?
When does it happen in the stream?
No,
Before...
about the clots?
Shape of the clots, whether it is tubular or irregular in shape.
Yes, if it is giving a specific shape, tubular or long tape-like clots, what do you think about it? What is your interpretation?
Upper tract.
Yes, it's unless proven otherwise, they are coming from the upper tract. But the other side, which is not true, if you get amorphous clots, there's no particular shape, which could be either from the upper tracts or lower tracts. But specifically, if you see clots taking a shape of a long tape-like or tubular-like clots, it's unless proven otherwise, it's upper tract bleeding. Okay, that's about clots. Anything else you want to ask in the history?
So timing?
Hematuria is from the beginning at the end of the maturation.
So what is the significance? Can somebody tell?
At the initiation of micturition, it's most toward urethritis, urethral strictures,
Yes,
urethral.
because correct. That is a traditional expectation. If it is more early, most likely it's from the urethra, right? And then
If it is at end of the bladder CA, bladder stone.
okay, yes, it's possible. Bladder, the bladder neck area. But remember, this theory is no longer valid. And in fact, now I don't ask about the relationship with the stream. But in traditionally, going with the traditional system, you can ask about the relationship. But it doesn't matter. Sometimes you do see patients with bladder tumors having throughout hematuria, or maybe towards the end, or maybe towards the initial phase. So it doesn't matter really whether it's a beginning or the entire stream or the towards the end. But remember, if somebody asks you, and that is the interpretation you are going to give, which doesn't have much of a clinical significance to me as a urologist. Okay, what else do you want to ask in the history now?
Any associated factors like loss of appetite, loss of weight, and fever?
So why do you, okay, fever. Why do you ask about fever?
To exclude urinary tract infection?
Yes, you can't really exclude any other conditions other than UTI could give rise to fever in this patient.
RCC.
Yes, RCC, very good. Paraneoplastic syndromes, don't forget them. Remember, RCC is well known for paraneoplastic syndromes. So if they come with fever, still RCC is a possibility. I'm referring to pyrexia of unknown origin, not just fever of one day. So don't mix up things. Okay. Anything else you want to ask?
Lower urinary tract symptoms.
Lower urinary tract symptoms. Why do you want to ask about lower urinary tract symptoms?
Can be due to BPH.
Yes, if the BPH is there, yes, you have both voiding and storage type lower urinary tract symptoms. Anything else?
Urinary tract infections can cause storage type.
Yeah, sometimes even the chronic infection, chronic irritation, and time to time they can experience lower urinary tract symptoms, particularly the storage, irritative type of symptoms, frequency, nocturia, urgency, those could be there. The females, the girls, you may remember when you get a cystitis, you always run to the toilet. That is because of the irritation, right? Anything else?
Other constitutional symptoms like sweating,
No.
loss of
Still we are
weight.
in the lux. Anything about lux? Low urinary tract symptoms? Any other condition out of the basket that we are discussing could give rise to lux?
Diabetes.
Okay, correct, diabetes. No, but with reference to hematuria, the DDs?
Obstruction?
Due to what?
Bladder carcinoma?
No, bladder carcinoma doesn't cause any outflow obstruction. That's a bit of a too theoretical way of thinking.
Bladder neck stones.
No, not bladder neck stones, even any bladder stone, or maybe vesicoureteric junction stone, they could give rise to lux.
Strictures?
Yeah, but strictures will not cause hematuria. Bladder cancers, can they cause low urine tract symptoms? What do you think?
Yes, sir, because if it's bleeding, blood itself is irritating.
Yeah, even without bleeding, when there's a mass, when there's a tumor inside the bladder, the tumor itself can irritate the bladder because it's a space occupying lesion which can irritate the bladder. So these people, when there's a tumor inside the bladder, can experience storage type or the irritative type of low urine tract symptoms. So remember, don't narrow down your thinking process. Any of these things, BPH can end up with LUTS, or maybe a stone inside the bladder, or maybe VUJ stone. Any chronic cystitis can end up with the hematuria and LUTS, particularly irritative type. If there's a bladder tumor, they can have LUTS. So remember, all these things could give rise to LUTS. Okay. Anything else you want to ask in the history?
Any bleeding tendencies?
Bleeding tendencies you can ask, but it's unlikely somebody will wait until 65 years to get the hematuria due to bleeding tendency. I'm referring to all these bleeding disorders. But of course, the other conditions, acute bleeding things can happen even in the elderly, right? What else?
Whether he had acute urinary retention previously, episodes.
Anything? Imagine you are taking a history from a long case patient. This is your hematuria patient.
Other causes of red color urine, like any reason, blood transfusion for hemolysis, strenuous exercises, and pseudohematuria causes like food like beetroot and medication.
It's all in these small notes, printed notes and things, but in practicality. Now, if you get a patient to clinic coming with saying passing red colored urine, you don't ever ask about beet, no? You never ask about drinking Portello or Necto. That is more of a theoretical.
You can ask about renal cell carcinoma features, flank
Yes.
pain, like.
So what are the classical other features apart from hematuria?
Flank pain or a
Flank
palpable
pain.
mass.
Where you get the palpable mass?
A flank mass.
No, you never examine. Have you ever examined the loin area for a palpable mass? Where do you find the mass? Yeah, you get the mass in the abdomen. Probably one of the hypochondrial areas. So it's abdominal mass, loin pain or flank pain, loin pain and abdominal mass. Those are the other two classical things. And remember then going through the entire list of paraneoplastic syndromes and related symptoms. Anything else in the history?
Whether patient is taking any blood thinners like warfarin, aspirin, clopidogrel.
Very good. And you need to focus about drug thinners. Why I think about drug thinners and the antiplatelets?
They are high tendency to the bleed, and if the bleeding is occur, it is massive.
Okay, that's one aspect. What else? What is the other importance for you as a surgical candidate?
For management of the patient.
Management of the patient, of course, the management of the bleeding itself, it's important. What else?
Surgery, we need to withhold.
Yeah, in case if you want to do a surgery, you need to think about these drugs. And remember, now there is a myth. That's good that you brought this up. And a lot of medical boards, our medical colleagues, whenever they see a patient who has been on warfarin, who has been on aspirin, who has been on clopidogrel, and of course now you have a lot of modern antiplatelet drugs, such as
Doax.
Rivaroxaban.
Yes, you have so many. So if you pick your patient has been on these drugs and he presents with hematuria, never attribute this hematuria to these drugs. Just because they do take drug, they don't bleed. They are at a higher risk of bleeding, but there should be another trigger for them to initiate the bleeding. At least there should be some inflammation, inflammation, or maybe some structural abnormality there. Then only they bleed. The common the management is whenever you find these patients are on drugs, especially antiplatelets and the warfarin, you tend to attribute bleeding to these drugs and you say, okay, that's fine, because you are taking these drugs. So, and you give a reassurance to these patients, which should never be done. I had enough examples in my practice. Patients are on antiplatelets and you do the full evaluation for hematuria, and at the end you find there's a tumor in the bladder. At the end you find there's a small renal tumor in the kidney. So therefore, always look for another cause. Never attribute without going through the full evaluation. Never attribute that hematuria to these drugs. That's number one. Another common scenario at the GP level, whenever they come with hematuria and maybe bit of a lux and dysuria, you tend to attribute this hematuria to UTIs. You do UFR and pus cells are there, and you very easily, okay, you had a UTI, prescribe some antibiotics. Unfortunately, hematuria settles and you are happy, patient is happy. Until he develops the next episode of hematuria, maybe after several months or maybe after a year. So that's the second mismanagement. The third mismanagement, when they come with hematuria, you maybe do an ultrasound scan, you pick up, there are tiny little stones in the kidney, calyces, maybe 2 millimeter, 3 millimeter, 4 millimeter, tiny little stones in their kidneys, the calyces. And straight away, you attribute that hematuria to these tiny little stones. You are having stones. Maybe you have bled because of the stones. Of course, stones are common. But hematuria, unless you actively look for another cause, but potentially the sinister cause, unless you exclude them actively, never attribute bleeding to these. Remember, even with the malignancy, you get one episode and you don't get a continuous hematuria, get a pause, and the second episode may be after several months down. So always actively look for, as a clinician, as a doctor, you should never attribute hematuria to antiplatelets, anticoagulants, and presence of stones or infections. Of course, these can trigger the bleeding. They can make the bleeding worse, but always look for another cause. That's important. That is one of the take-home messages I want all of you all to take back in your memory. Okay, anything else in the history? Quickly, we'll run through.
History of trauma?
Trauma, yes, but again, if somebody is coming with hematuria over several weeks, months, very unlikely it's a trauma. But maybe just one episode, yes.
A scrotal abnormality that the patient might have noticed.
Why?
Because left-sided non-reducible varicocele are
Yeah, I would
associated
say
with
unless the patient is a medical person, don't try to diagnose varicocele with your history. Try to always go into the examination and identify that. In the history, more important things.
What drugs he is taking for diabetes?
Yes, what drugs, it's important because we mentioned the reason.
Travel history to the endemic areas like Africa and being long times there.
Yes, travel history, more than travel history, they need to live there for a while to complete the cycle. Okay, that may be important, right? Okay.
family history of carcinomas.
Family history, of course, yes. The family history of renal cancers and sometimes certain types of bladder cancers. So family history is very important. You need to go into depths. Anything else?
Past history of contact history of TB?
Okay, if you're thinking about TB, but as I mentioned, TB causing hematuria is less common. So don't pay very high focus on this, but you can, but just passing by, you can ask about it, but not very relevant. I would not penalize if you don't ask it. But if you don't ask about the family history, definitely I will penalize as an examiner. If you don't ask about the habits, the smoking history, definitely I will put you down. And there are comorbidities, especially the chronic hypertension. That is important. Anything else?
Any history of pelvic radiation therapy that can cause?
Okay, history of pelvic radiation. Why?
The history of pelvic radiation therapy can cause radiation cystitis.
Very good. Radiation cystitis is less common, but we do see. But remember the other thing, radiation could be maybe even 6, 7 years or even 10 years back. And they could bleed. So if there's a clear history of pelvic radiation, that is another differential diagnosis that one should entertain in the list. Radiation cystitis, radiation hemorrhagic cystitis. Anything else?
Features of
Complications of chronic bleedings, anemia.
Sorry?
Complications related to the chronic bleeding.
Okay, complications such as
blood loss, anemia.
blood loss, anemia, symptoms of anemia, the lethargy, easy fatigability, all these things could be there. That will indicate, in other terms, significant bleeding over a long period. Just remember, just 1-2 episodes of hematuria, they don't end up with anemia, like rectal bleeding. What else?
Features of distal.
Industrial exposure.
Features of distal.
Yes, somebody was saying about the occupation, industrial exposure. Yes, we have already discussed about that, but definitely you need to ask that in the history. If you don't ask about the history, that's important. And remember, another small thing, you need to be a bit practical. Sometimes the females, you are taken for granted, they don't smoke. But nowadays, I do quite frequently, there are smoking females everywhere outside. So just because it's a female, don't hesitate to avoid that history. Always ask about smoking. And the other thing, females, how do they get smoking exposure?
Passive smoking.
Passive smoking. So always think about household, the other occupants, whether they are smokers. So there could be a very significant history. Maybe the spouse, the husband could be smoking over a long period, and that's the passive exposure. That's important. Right. So, and somebody else mentioned something else. I moved a
Features of distal involvement like chronic cough, hemoptysis.
Right. So if you're thinking about a malignancy, then you are worried about the staging, the distal spread. In the case of bladder cancer, where do you get the metastasis? Common sites? Locally advanced disease is something else. Let's say locally advanced disease, bladder cancer. Where can it spread?
To the lymph nodes, and if it's to women, it can spread to the vagina, the rectum.
Yeah, local spread, it could involve the gynecological structures, and the posteriorly more commonly is the rectum. If the rectum is involved or the sigmoid colon is involved, what can happen? Long-standing bad tumors.
Hematuria.
Sorry?
Patient presents with fecaluria.
Yes, the fistula. Colovesical, rectovesical fistula. Very advanced cases that can happen. So you can ask about fecal urea, pneumaturia and things that could be significant, or maybe recurrent UTIs. That's one aspect. And sometimes which can involve the spread posteriorly, involve the sacrum, the nerves plexus, the severe pelvic pain could be there. And because of the involvement of the lymph nodes, and you can get ankle edema bilaterally, the lymphedema. Patient can have bilateral ankle swelling, lower limb swelling. Remember those things. Okay, that's lymph node involvement, especially pelvic lymph nodes, very common with the metastasis, very common with bladder tumor. Where else can they spread bladder tumors?
To the ureters.
Okay, that's a locally, okay, right, involvement. Anything else? Sorry?
Bones.
Yes, bone involvement, lung, liver, brain, they are there, but it's less common compared to other tumors. Let's say you get a colorectal cancer, they will spread more commonly into the liver, lung and things than the bladder cancer. But of course, bladder cancer do spread to lung, liver. It can happen, especially lungs. It can happen. Right. How about the renal cell cancer?
It can grow along the vein.
Pulsatile bone lumps.
Yes, renal cell cancers can spread anywhere in the body. Very aggressive, very fast spreading, and along through the bloodstream, they can end up with anywhere. Classically, you will see the lung, liver, brain, and bone mets. Very high chance of getting bone mets, and if there are bone mets in palpable areas, they will be highly vascular, pulsatile bone mets. So that's another aspect, right? And upper tract urothelial, they are also very notorious. Involvement, liver involvement, අර ඔයගලගේ වට්ටෝරුවක් තියෙනවනේ අහගෙන යන්නේ. කට පාඩමින් අහගෙන යන්නේ. ඒ වට්ටෝරුව අහන් යන්න පුළුවන්. And brain mets and things, then you can focus about in the history, right? Okay, so I think the history we have covered quite a lot, and then your social history and things you need to adapt to this, and I'm not going to go into details. Examination, what are the things you want to focus? Students?
The patient's build, anemic features.
Okay, anemia. Is it only anemia are you worried?
No, plethoric also.
Yes,
Polycythemia
plethora is
as
also
well.
important. Why?
Polycythemia is a
Yes, polycythemia is a paraneoplastic syndrome of RCC. Right. Anything else?
if there's a varicocele.
Yeah, no. We go in order. We are in the general examination.
If there is liver mets, can be jaundice there.
Okay, icterus, yes.
Cachexia.
Yes, if it is RCC, very, very advanced disease. And of course, the loss of weight, loss of appetite, you do see with RCC, but less common with bladder cancer. Remember, bladder cancer usually you don't get unless it's a very advanced disease. RCC also, it's a bit advanced, you get the loss of weight and loss of appetite. And so, cachexia, the advanced tumors, you can get wasting, right? So, ideally, you should be checking the what? Checking what? The weight, height, and you should ask for the BMI. And what else?
Enlarged lymph nodes
Yeah.
like supraclavicular.
Yes, very good. Supraclavicular lymph nodes. Especially which node? Which side?
Left side.
Left side. Why? What do you call if it is enlarged? Palpable. Virtuous node. Yes. And which malignancy are you worried if it is there? Out of the lot we have mentioned? Renal cell cancer, yes. Okay, what else? So you look at the lymph nodes, neck nodes, and particularly the left supraclavicular nodes. Okay, and then maybe you can look at the features of renal impairment. Certain malignancies can interfere with the ureters. They can block the ureters, particularly advanced bladder cancers, they can block the ureter. And in case if you find both ureters are blocked with a bladder cancer, or even if one side is blocked with a bladder cancer, what do you think about the disease stage?
Locally advanced bladder carcinoma.
Yeah, it's unless proven otherwise, it's a muscle invasive bladder cancer. Superficial bladder cancers, they never cause hydronephrosis, hydroureter by blocking the ureter. If you get the ureteric obstruction with a bladder cancer, that has to be muscle invasive bladder cancer unless proven otherwise. Okay, now coming to the abdomen proper, what do you want to check? Your patient, 65-year-old man coming with hematuria.
Abdominal masses.
Sorry?
Abdominal masses.
Yes, abdominal distension, asymmetry, and then obviously when you palpate, you look for the masses. You look for a palpable mass. Yes, tenderness could be, and then the palpable mass, especially the hypochondrial, right, left hypochondrial, or the the flanks, the lateral areas, the masses more signifies signify the renal tumors, whereas the suprapubic mass could be a bladder mass. And please go through and find out how to differentiate the tumors arising from the pelvis, how to differentiate clinically, and these things which are important, right? Okay, what else?
Palatable masses.
Palatable masses you get with renal tumors, renal masses, but the mass has to be really big for it to be palatable. It's less common, but still one could get with the RCC. What else?
Surgical scars.
Surgical scars, yes, previous surgery may be related to present episode. What else?
Bladder dullness.
Okay, residual volumes, bladder dullness, okay.
Renal
Ascites.
Ascites, free fluid, yes. What else? Hepatomegaly, aren't you looking for the liver? If it is palpable, what will you do? Now let's see your patient, this particular patient. You can palpate the liver, 2 finger widths down the costal margin. What will you do? What is your next step?
I will check for the upper margin of the.
Why? Why it is important for this particular patient?
Because push down liver can happen if there's if the lungs are expanded.
So what is the relevance to this particular patient?
The patient
He's a smoker, so
Yes,
COPD.
smoker can have COPD, and then probably it could be the liver which is pushed down rather than enlargement. Remember, your patient is a smoker, so can have all the features of smoking in the lungs. Right? What else? And you can, the general examination, you will see features of chronic smoking. If you look at examine the fingers and the lips and the soft palate, there could be staining. And anything else in the abdomen? The golden rule, your abdominal examination is not complete unless you complete the examination of genitalia, rectal examination, and palpate for the bilateral femoral pulse. 3 things. If you don't do, your examination is not complete, abdominal examination. So genitals, how will it helpful? How will it help you?
Inguinal hernias due to bladder output obstructions.
Okay, that's one aspect if you are thinking about the BPH.
Left varicocele.
Varicocele, especially left side, especially you used to know the left side, the testicular vein which drains into the renal vein. And so what is the mechanism? Why do you get varicocele in the presence of RCC, especially left side?
RCC invades left renal vein. So due to the obstruction.
So what is classically what do you see inside the renal vein?
Renal vein thrombosis.
Yes, it's not renal vein thrombosis, that's a tumor thrombus. RCC growing along the renal vein and which can even come into the IVC, which is very classical and characteristic of RCC to have a tumor thrombus along the vein. Remember. So the renal vein is blocked and then patient can end up with varicocele on the left side. Right side, of course, the testicular vein directly drains into the IVC. So it's uncommon unless there's a big, large tumor thrombus in the IVC. It's very unlikely that they end up with right side varicocele, but left side, of course, much more common. Anything else?
Bimanual palpation in female patients.
Okay, we're looking for the pelvic masses. Anything else? The rectal examination?
The prostate.
Yes, prostate, because one of your differential diagnosis is BPH. So look for the prostate. Get the characteristics, whether it's a benign or a malignant, you get the characteristics of the prostate. Maybe you are dealing with the prostate cancer. You never know. So look at the prostate. If the patient is having classical LUTs, And then if you examine the prostate, either benign or malignant, then there is one thing that you need to focus. Okay, let's move on. So how do you investigate this patient?
Urine full report to confirm hematuria.
Okay, urine full report to confirm hematuria. Let's say your urine full report is negative. Will it change your management? Your answer is correct, but I'm asking a different question. Let's say you are this particular patient having intermittent hematuria coming to your clinic. You get a UFR done, which is perfectly normal. Do you chase the patient out? Don't lie, your urine is normal, there's nothing to worry. Go home. And do you send the patient back home?
No, sir, I will further investigation.
Yeah, of course, because these people can have intermittent nature bleeding. So therefore, at the time of sample collection, it could be a normal sample. Doesn't mean that the patient is not having hematuria. If the patient is red colored urine, you have to accept, you have to trust the patient and investigate fully. Okay, anything else?
Full blood count to see hemoglobin.
No, before that, about urine?
Urine for cytological examination.
Yes, before that, and if there's any evidence of UTI,
Culture.
if you suspect the UTI, then how do you confirm the UTI?
Urine culture.
You need to send a urine culture for culture and ABST. With UFR, you can't confirm a UTI. You need to have a urine culture. That's right. And somebody mentioned something else. Yes, urine for cytology. What is the significance?
We can see malignant cells.
What is the
in
mechanism?
In bladder cancer, it's a very friable, so it'll slough off. And
is it bladder? Is it only bladder or elsewhere?
Dysmorphic RBC.
Yeah, before that, just leave it aside. I'm talking about the malignant cells in the urine.
Can also be from other side.
It could be from upper tract urothelial. But how sensitive your urine for malignant cells? Is it a good test or a bad test? What do you think? We need to finish quickly. I'll give you another half.
It's good.
Yeah, if it is positive, that's good.
But if it's specific, but
Bad test.
Yes, because the sensitivity is poor. Because a lot of bladder tumors, they don't shed, they don't have exfoliating cells. The chance of having tumor cells in urine is higher if you have a poorly differentiated bladder tumor or a poorly differentiated upper tract urothelial tumor. If it is a well differentiated tumor, chances of getting tumor cells in urine is less. So the sensitivity is not very good. That's number one. Number two, you need to have a large volume of urine and you centrifuge, and then only you need to examine for the cytology. Otherwise, you don't get enough numbers to be positive. Number three, it has to be freshly collected sample. Already collected some time back, now sending to the laboratory tomorrow, that is not going to help you because all the tumor cells could be destroyed. So there are a lot of hurdles when you are doing urine for cytology. Okay. Any other test?
Cystoscopy, if you
Somebody said urine for dysmorphic red cells. Why?
To exclude glomerular pathologies.
Yeah, glomerular pathology, which is very less likely. But after you exclude urological cause and still patient is having hematuria, then only we will think about medical causes and we will do urine for dysmorphic red cells. Otherwise, because the red cell shape is altered when they squeeze through the renal tubules. That's why you get the dysmorphic red cells. Okay, any other test you want to do?
Full blood count to see the.
Yeah, full blood count. Why?
I want to check the hemoglobin for the severity of anemia and the
yes,
platelets.
either low or high. for the same reasons I have mentioned.
And
What else?
platelets.
Platelets, yes.
And the white cell count in case of an
White cell count in the
infection.
presence of a infection, probably you will get a higher white cell count.
A PTINR.
What do you think the platelet count? Would it be low, normal, or high?
It can be high if there's polycythemia.
No, not platelets. If the platelet count is low, they are at a higher risk of bleeding. That's one side of the story. On the other hand, when there's a patient with acute bleeding, as a response, the body's response, they can have higher platelet count. So both ways it can happen. Okay. So what else you want to check?
Serum creatinine.
Okay, why do you want to check creatinine?
To assess the patient's current kidney functions.
Okay, baseline kidney function. How it is going to help you in this patient, in this assessment?
In the surgical management of the patient, if you're giving
before going to surgical
medication.
management, before going to that far.
The medication has to be the renal dose.
And no. More important things about hematuria.
You have to give
and
contrast to the patient getting
Yes,
KTs.
at some point this patient will need contrast imaging. So for you to give contrast, you should know patient's creatinine level. That is the significance. These are exactly the same questions I would ask in the long case if I'm in the discussion panel. What else? What are the other things you want to check?
An ultrasound KUB with full bladder.
Okay, ultrasound scan. So now we are slowly moving towards imaging. Okay, right. Let me change this one to talk about imaging a little bit further. Right, okay. Now, if you want to investigate any patient with hematuria, there are two essential components. Number one, you need to image the upper tracts. Imaging is essential to evaluate the upper tract. That is the kidney, renal, pelvic, ureteric, calyceal system, and the ureter. Whatever the good imaging, however the best imaging you have, if you want to evaluate your bladder and the urethra, you need to do cystoscopy. You need to visualize the lower urinary tract under direct vision. Unless you complete both these components, your assessment is not complete. So if you look at the upper tract imaging, these are the options available. Now, can you argue for and against about these imaging techniques? So somebody already mentioned about the ultrasound scan. So what are the plus points, good points, bad points? Can you tell me?
We can see features of upper tract obstructions with ultrasound.
Yeah, upper tract obstruction, yes. Which could be due to stones, which could be due to bladder tube invading the muscle, which could be due to prostate cancer, which is invading the bladder, which could be due to upper tract urothelial cancer causing stricturing of the ureter. Could be anything, right?
We can also see the liver.
Before that, just focus on
the papillary lesions that might be visible in the bladder.
Yeah.
In the bladder.
Bladder lesions could be seen, especially if they are big papillary lesions of reasonable size. You can see if you do the scan with full bladder with the experienced radiologist. Negative ultrasound scan will not rule out any bladder lesion. Remember. Anything else you can pick up in the ultrasound scan about your patient?
Stones in the...
Yeah, stones in the bladder, stones in the kidney, yes. But stones in the ureter, ultrasound scan is not a good modality.
Hydronephrosis, hydrouretic?
Yeah, we mentioned hydronephrosis, hydroureter, and I mentioned the reasons how do you get hydronephrosis, hydroureter. Focus more on urological malignancies.
If it's muscle invasive bladder cancer with local spread, you might be.
No, local spread you can't assess using ultrasound scan, especially bladder cancer.
Residual volume of
Yeah, that's
bladder.
a different aspect. How about RCC?
So we can assess the kidney shape, surface, and the corticomedullary demarcations.
Yes, those information you can gather. Plus, if there's a renal mass of a reasonable size, you can see in your ultrasound scan. Ultrasound scan is quite good. It will pick up a lot of renal masses. And in fact, nowadays, quite a significant number of RCCs we pick up as incidental finding in ultrasound scans. But can you rule out, can you exclude a RCC by doing an ultrasound scan?
No.
No. Okay, so if you are having a patient with hematuria, what is the imaging modality? The imaging modality of choice out of the given ones here?
CT abdomen and pelvis.
Yes, it has to be a contrast enhanced CT, either abdomen pelvis or a CT urogram. What do you think? Yeah, now you are having a patient with hematuria. So which one would you select? CT urogram or contrast enhanced CT abdomen pelvis?
CT urogram.
CT urogram. What is the reason?
So it's visualize entire urinary tract, which is functional and anatomical.
Okay. Now tell me, even the contrast enhanced CT scan abdomen and pelvis is good if you want to assess a renal tumor. The accuracy is the same as the CT urogram.
So you
Now,
can see
that's what
filling
we do.
defects.
Time, sir.
Yeah, it's a difference is the time, because CT urogram you do the late films, so you can see the draining tube, the calyces, pelvis, and the ureter that could be well picked up in the CT urogram. So why when you have a patient with hematuria, why it is important that you do the CT urogram?
You can identify filling defects.
Suggestive of?
Suggestive of upper tract urothelial.
Yes, upper tract urothelial cancers you can see as filling defects, number one. Upper tract urothelial cancers you can see thickening of the ureter, focal thickening of the ureter, which can be clearly seen in the CT urogram, but not in the CT abdomen pelvis, because the ureters are not filled with contrast very well. You get my point? So if you have a patient with hematuria, we always prefer to do a CT urogram. On the other hand, if you have a patient with hematuria, you do the initial assessment in the ultrasound scan and you see if there's a renal tumor, then I would rather consider contrast enhanced CT, chest, abdomen, and pelvis in one go. Because there you are not worried about the draining system, you are mainly focusing on the renal parenchymal tumor, for which the contrast enhanced CT abdomen pelvis is equally good. And of course, you will add the chest to stage the disease also. So it's important. Now, how do you confirm the diagnosis of RCC?
It can diagnose with CT, so don't want biopsy.
Yes, you don't perform biopsies routinely. You rely on the CT scan, contrast enhanced CT scan for the diagnosis. The accuracy is quite high. That's number one. Why don't you do biopsies?
Because kidneys have
Risk of tumor seeding.
Sorry? I didn't hear it.
Risk of tumor seeding.
No, benefit.
Yeah, tumor seeding, its risk is low. It was thought it's very significant earlier, but nowadays we know the seeding, tract seeding is very minimum. So that is not the main reason now.
No added benefits, sir?
No added benefit. Why? Can you explain? Elaborate your answer.
Either way, the histology type is, we can confirm the diagnosis with CTs.
Okay. Now let's say you do there's a renal mass, you do a biopsy and you get a positive results. Yes, you are happy, you have confirmed the diagnosis. You do the biopsy, you get necrotic tissue or maybe some normal kidney tissue, but no renal tumor. Are you happy to exclude and close the chapter there?
No.
No, because we can always miss a tumor. Because we know the renal tumors, there is significant necrosis in the center. So if you don't hit properly, you can always miss. That's number one. And the second thing, significant proportion of renal cell cancers or renal cell carcinomas are cystic tumors. Cystic or solid and cystic. So if you hit a cystic area, you will drain some fluid, but there will not be any tumor tissue in the sample. So by doing a histology, the FNAC or the co-biopsy, even if you get a negative result, you won't be able to exclude a renal tumor. So therefore, which is not going to change your management. That is why we don't encourage you to do a biopsy. If there's a tumor in the CT, the imaging, you need to take it out unless proven otherwise, unless you are quite certain you are dealing with a benign one. So that is not going to change your management, right? So therefore, either it has to be a contrast CT, obviously. Either it has to be a CT, contrast enhanced CT abdomen pelvis for the renal tumors, or maybe a CT urogram for the renal tumors as well as for the upper tract urothelial cancers. So if you are not really focused, you are just asking without knowing exactly what you are dealing with, I would say always ask for a CT urogram. Okay, so why do you want to do cystoscopy? Why do I say that is an essential part of your assessment, irrespective of the fact whether you do a CT or not?
So in bladder carcinoma, if we see the tumor in cystoscopy, we do the TURBT.
Yes, the reason is whatever the best CT, whatever the best MRI you have, still there is a chance you can miss a bladder tumor with your imaging. So therefore, your imaging is not a substitute for your cystoscopy. Your visualization, direct vision is much more sensitive than your imaging. Therefore, in order to complete the assessment, to look at the bladder and the urethra, you need to do the cystoscopy. Ideally, we do flexible cystoscopy because which can be done under local anesthetic as an office procedure. So you can have varying type of tumors. Here you could see a papillary one here where my cursor is, or you could see red patches, carcinoma in situ, or maybe flat lesions, or maybe you can see a solid lesion like here. So different types of bladder tumors are there. Okay, can I ask a question? If you see a bladder tumor in the cystoscopy, do you do a biopsy?
No, sir, because we have to do TURBT, however.
Yes, you are not going to do a biopsy because biopsy is not going to change your management. Let's say you do a biopsy, which is coming as positive for a bladder tumor. You are not going to stop at that point. You need to do a proper resection. You need to remove the entire tumor. Therefore, doing a biopsy is just a waste. And if you see a typical tumor, you don't do biopsy. But of course, if you see some red patches, like in this first picture, the upper first picture, then you are not quite sure whether it's an inflammatory lesion. At that situation, you may decide to do a biopsy. But if you see a typical bladder tumor, never do a biopsy. Straight away prepare the patient for a transurethral resection of bladder tumor, which is going to be therapeutic. So, and then I'll change the slide. How you investigate, and remember your imaging is important, especially for staging also. In the presence of a malignancy, your CT urogram or the contrast enhanced CT abdomen pelvis is very good to identify the tumor stage. You can see if it is a bladder tumor, you can see the depth, how far which is spreading, whether the local involvement, the lateral pelvic wall involvement, whether there are pelvic nodes or whether there are para-aortic nodes, the rectal involvement. If it is a renal tumor, you can see the tumor size, whether it's breaching the capsule, coming out, and whether the Gerota's fascia is breached, whether it invades the local structures, whether the adrenal is involved, whether there's a single tumor, multiple tumor, bilateral tumors, whether there's a renal tumor thrombus in the IVC or maybe in the renal vein, or maybe the nodal disease, maybe metastasis in the liver, lung, whatever it is. So the tumor staging can also be completed using your contrast enhanced CT. So how do you treat now?
So it depends on the stage of the.
Number one, it depends on, now you are focusing on your patient, this particular patient. It depends on the underlying pathology, your diagnosis, and the stage, and a lot of patient factors, and then the expertise available. So that's a different topic. I'm not going to touch upon that, because you need to read about separately, read about renal cell carcinoma, read about bladder tumors at least, because any of you can get a bladder tumors. You should know the proper management. Please read. And the students, my students, they usually get a good guidance as how to manage these two tumors. And please read about the two tumors separately. But I want to focus few things. I would say, when somebody is coming with hematuria, significant hematuria and clots, there's an acute treatment and there's a treatment of underlying condition, or that is the definitive treatment. What do you mean by acute treatment?
Symptoms, post-symptom release.
So let's say somebody is coming with visible hematuria, frank hematuria, gross hematuria with clots, and he's struggling to pass urine. What will you do? He's there at the A&E, can't be in the clinic. Usually these people, they are coming as casualty. Gross hematuria, thick blood, they are passing, not urine, it's purely blood. You are seeing this patient at the A&E. What will you do?
Bladder irrigation.
Yes. Before that, you need to admit these patients. If they are having frank hematuria, straight away you need to admit. After admission, what will you do? If they are having a very bad bleeding, what will you do?
So we have to assess the patient whether the patient is hemodynamically stable or not.
Yes. Now remember, hematuria could be one episodes who's coming as an outpatient like our index patient, or maybe very severe bleeding coming as an emergency. If they are having a very severe bleeding emergency, please assess their stability. That's very important. You assess the hemodynamic stability, get good cannulas in, venous access, take blood samples, full blood count, coagulation profile, and grouping and cross-matching. But remember, you don't do the same thing for another patient coming with intermittent hematuria, coming to your clinic. You don't jump and admit and try to put cannula and take the blood for grouping and cross-matching. That's a different treatment. I'm talking about acutely severe bleeding coming as an emergency. You need to do the emergency treatment. So if the patient is pale, very badly pale, what will you do? You may have to transfuse blood. If they are having thick hematuria, what else will you do? What is the risk if you just leave them like that?
Hemoglobinuria.
Not hemoglobinuria, I mean
clot retention.
Yes, clot retention. If you just leave frank hematuria without doing anything, in no time they will make a clot. And if they form a clot inside the bladder, they will find it difficult to pass. So to prevent clot formation, what will you do?
We have to insert a three-way catheter to the patient and blood irrigation.
Yes, you need to insert a three-way catheter and start blood irrigation. The bladder irrigation is helpful to eliminate, to wash out frank hematuria, the frank blood inside the bladder, so that it will prevent clot formation. If the clots are already formed, what will you do? Let's say the clots are there and your catheter is getting blocked time to time.
Do a cystoscopy and wash it?
No, before that, in the ward setup, you house officers, what will you do?
We can flush the catheter with using a normal saline.
What will you use? What will you use?
Normal salines?
No, yes, normal saline, that is 0.9% sodium chloride. There's nothing called normal saline, which is abnormal, which is not normal. And so what will you use? What is the instrument used to give an effective bladder washout or bladder the cleaning?
Sir, 50 cc syringe.
No, not the best. You have to use a bladder syringe. The problem with the 50 cc syringe, the fitting the syringe to the catheter is sometimes difficult. But if you use a bladder syringe with a conical shape, the nozzle, and it will nicely fit on, and you can carry out bladder washouts very effectively with normal saline. When you give bladder washouts, you can break the clots, small clots, and you can eliminate and wash out the bladder clots. If that is not successful, still they are having clots and clot retention, then as somebody mentioned, you need to take the patient to the theater. Under anesthesia, you need to do a cystoscopy and clot evacuation. So that is the acute part of the management, and then once the hematuria is under control, then you offer further evaluation for the patient. Imagine you struggle to get a three-way catheter in a patient with hematuria. Will you attempt suprapubic catheter?
No, sir, because if there's bladder carcinoma, it should never be done.
Yes, number one, if there are clots, you are not going to take these clots out through a suprapubic catheter, number one. Number two, in case if there's a bladder tumor, when you put a suprapubic catheter, what will you do?
Tumor seeding.
Tumor straight away, they can spread along the catheter tract, suprapubic catheter tract. And you will make the initially confined to the bladder, inside the bladder, and straight away you can make it T4, which can involve the abdominal wall. So therefore, any patient with hematuria, if you can't catheterize, straight away do a referral to the urologist, get them to do a cystoscopy, and then try to get a catheter with the aid of cystoscopy. Hematuria retention, never try to do a suprapubic punctures because of the risk of bladder tumor, underlying bladder tumor, and without your knowledge, you may spread the disease. Okay, that's all about evaluation, and of course treatment. It's too big, too vast to discuss during a small time. So you should know the treatment of RCC, treatment of bladder tumor, treatment of stones, and treatment of BPH. Depending on what you find in your patient, this particular patient, and we will take you through the relevant management. So before we sum up, please, any burning questions up to now? So please go home, read around the theory, read about the topic, and make your own sketch and how to take a history from a bladder tumor patient. How to take a history from a hematuria patient. And I would rather prefer, rather than typing the messages, I would rather directly raise the question and ask. So far, the messages, how long duration? Hemodialysis is a risk factor for RCC. Usually, if it is more than 5 to 10 years. At least it has to be usually 10 years more or more. So does biomass smoke exposure also has some effect on smoking in bladder cancer? What do you mean by biomass smoke? Can somebody elaborate? What do you think about biomass smoke? So after TURBT, do we see whether muscle invasion by those samples? Of course, yes. When you do a TURBT, you remove the macroscopic tumor and then you resect the tumor base. By resecting the tumor base, you take the deeper layers, including the muscle wall, and you send it for analysis. And then your pathologist will be able to tell whether this tumor is invading the muscle. Sir, for ultrasound scan KUB, do we need to prepare bowel? Answer, no. Ultrasound scan KUB, no need of bowel preparation. And also, can you explain on chronic urinary retention? Chronic urinary retention is a condition where you have gradually, you are keeping a large volume of residual urine and gradually you build up, and which is a painless condition. And typically you can accommodate very large urine volumes far exceeding 900 milliliters. Sir, can we know about how surgery short cases proceed in final exam? Yes, you have two bays. So we divide short cases into different types. Now abdomen and pelvis and lumps, bumps, hernias, and then you have orthopedic cases, and you have all these other conditions. You divide into two bays. You never overlap the cases. So you are supposed to do 2 short cases in one bay, and then you cross over to the other side and you're supposed to do 2 more cases. So 10 minutes each in particular bay. So you will be meeting 4 examiners in 2 bays. Sir, can prostate cancer also present with hematuria? Answer is yes. Prostate cancer do present, especially when it's a locally advanced disease. When it is invading the bladder, they do commonly bleed. But early prostate cancer, the prostate cancer confined to the prostate itself is less common to bleed. Is there any place for tranexamic acid to prevent clots? Yes, if there's a gross hematuria, selectively you can give tranexamic acid. There is no contraindication. Sir, even if ultrasound scan shows a renal mass, do we still do the cystoscopy? If you are quite sure the history is very suggestive and you know you are dealing with the RCC, of course, then which is not needed. But if the renal mass may be upper tract urothelial cancer, then definitely you need to do the cystoscopy. Any questions? Please ask. Okay, in the absence of questions, I think it's time to wrap up.
Okay.
Hope that you get at least something out of it. Thank you. Thank you for your patience and listening.
Thank you very much for it is a very comprehensive discussion, interactive discussion. I think you learned a lot about management of hematuria. In the beginning, I told you he's the ideal person to discuss about this topic. I think you realize that how much he explained it, and it is a very understandable discussion. I also learned a lot. Thank you very much, Dr. Ranga Wickramarachchi. I have to tell something else tomorrow. Tomorrow that we have another discussion. It is about management of chronic pancreatitis. It will be done by Dr. Buddhika Disanayaka, Senior Lecturer, Consultant Hepatopancreatobiliary Surgeon from Faculty of Medicine, Peradeniya. We will let you that exact time tomorrow. Dr. Ranga, thank you very much. Good night.
Okay, thanks. Good night then. Thank you for the opportunity.
Excuse me, sir.
Yeah.
Sir, thank you for this valuable session conducted for us. And there's a small request as well. Sir, can you do another session like this on LUTS as well, sir?
Okay, we will. I will let you the timing through Dr. Dixon, and maybe a few weeks later, we'll see.
Thank you, sir.
Right. Okay, thank you.
Good night, sir.
Sir.
Thank you, sir.
Okay, good night.
Thank you, sir.
Thank you, sir.
Um,